Okay, Margaret?
Thank you, Sheila. We had an exceptionally rich discussion in the research group. And so our stealth strategy for sticking to five recommendations was to have a lot of detailed subpoints, which are before you now. The group spent some time discussing the need to better understand why policies don't get implemented. In fact, that oftentimes we're trying to solve for some quality problem, but there already is a policy on the books that hasn't really ever permeated down to the ground. And to understand that not in a particularly theoretical way, because in fact there are a lot of theories one can lean on to understand policy implementation, but to practically assess settings in which that happens and in which it doesn't, and try to understand how we can promote good policy uptake. The second area that we, I think, had widespread agreement on was the importance of measuring better. This area of quality improvement, which is similar really to the broader area of health systems research, is littered with hundreds, if not more, thousands really, of indicators and measures, some of which arose from vertical programs, from particular needs, donor needs. And unfortunately, it really inhibits our ability to learn from each other. And so what we stipulated here is that we need to standardize process measures in particular. Outcomes are better. We're better in outcomes. We all agree on how to measure under 5 mortality. But process measures need to be much more tightly defined and a small sample, I think, selected. Identifying gold standard measurement approaches is still a struggle. We know standardized patients work in some settings, observation work in other settings, and self-report and perhaps others for other kinds of information. But really characterizing what works best in for what questions would be very important. Again, so we don't waste time and money. Improving reporting of the implementation process. I think it's a common observation for many of us who do evaluation work or do peer review of that work, that often you have a beautifully described evaluation and you have no idea what is being evaluated because the actual program, the implementation, the very gut of the thing is actually not defined. So really improving both the qualitative and the quantitative reporting of what was implemented. Which would also help for external validity and generalizability of the work. Third is improving the rigor of study design. Specifically, we spoke here about the need for more prospective studies that are evaluations that are really baked into the very design of the quality improvement so that we can learn as we go. And that also we can use log frames, as was proposed, that are designed maybe for project monitoring, but also can be very useful for evaluation if evaluators are allowed to participate in at the beginning. Secondly, the critical need for longer studies. 6 months, several people made this point, 6 months is just not enough to know whether something will A, work, B, stick. So we really do need longer studies. And finally, more replication of studies and in different contexts, ideally. Number 4 is, and this was a difficult one to characterize because our group had a lot of discussion about this notion of who gets to decide what the solution to the quality problem is? At what level is the right solution? So the notion about diagnosing the quality problem, what is the nature of the problem, the root of the problem, the drivers before implementing the solution, because that allows us to assess the appropriate level for intervening. Is that level a policy solution that's required, a regulatory solution perhaps, or is that a facility level intervention? What about the evidence for the existing approaches? Is the existing approach, or one of the 6, for example, approaches that we're examining here, how well does it fit with local context? If it's a management approach, is there actually management that will be able to absorb that solution? Assessing leadership, broad-based capacity in the clinic, and folks recommended also just understanding baseline performance before you implement any solution. Because that may affect the effect size. Finally, free the data. So this, as a large frustration, both with the insufficiency of data, there's just inadequate data in low-income countries in particular, and I think we emphasized the fact that middle-income countries are already so much better on this front with administrative data and routine data sources. The lack of readily available high-quality routine data is hindering progress in healthcare, I think to a huge degree in low-income countries. And again, other countries, Mexico, middle-income, upper-middle-income countries have really done a tremendous amount. And so what can USAID do in those lower-income countries to help build common information infrastructure? What can it do to advocate? Maybe it's not the health team that does that. Maybe that's part of the other development processes that are being encouraged. But it's a public good that is hugely important. Advocate for data sharing across projects. So where there is data, often the data are actually not shared, not shareable. Governments hold them close to their chest. USAID holds project data close to its chest. And I know there's a project underway now to try to open that up and have a common, we heard, have a common registry of projects that would report what happened, would report on measures. And I know we heard earlier, Pierre, about sharing successes, but we think it's equally important to share failures. If something seemed to be so promising in place X, but failed in place Y, that opens up a rich vein of questions about, what about context was really important for success. So we think that common data platforms, data repositories are a perfect thing for a group like USAID to really invest in, both for its own programs and to support that kind of sharing in country, to insist, as it does now increasingly, for example, that USAID funded data collection be a public good and be publicly available. So those are the kinds of convening powers that I think are well within USAID's capacity. I look forward to any input from group members to round this out.
Yeah.
Just the one thing I would add, Margaret, was maybe just thinking about the governance of the entire structure, because it seems like USAID is a federal structure. There are country units, and then there's the center.
Just know, I was actually in your group when you were making this point. I think it's a very important point, so I'm going to ask you to elaborate now. And please pull forward. Yeah. Thank you.
So one problem, I worked with several donors, and usually what I find is there is no clear idea at the bottom about people are asked to do things, and then over time they're asked to do more, and those asks keep changing. So I'm assuming that the usual USAID project, if it's like other donors, would be, we have money till 2016, can you come in, set this up by tomorrow, and use up this funding? Whereas the places where I think and then it's actually needed to say, look, the secretary needs a number by Wednesday saying 42,000 people were trained. Do we have that number? Yes, no, here's the target, here's how to do it. And moving from that to research, it seems it'll be very easy to say, look, the bottom should do more. But every time we have gone down the line of saying the bottom should do more, unless there's a governance and legislative agenda up top, it's failed. And by the governance and legislative agenda, I mean, for instance, should projects be peer reviewed externally to USAID? What should the governance arrangement over the data be? Who is collecting the data? Who is responsible for collecting the data? And the problem has been, unless those are legislated ex ante, they become almost impossible to handle over time, right? So, we instituted this in the bank that, Dinesh can tell you more about the results-based financing, but that legislated an impact evaluation for every project that went in the field. And it was legislated ex ante precisely to make sure that the governance arrangements were very clear in terms of what's the central role and what's the role in the country. And I just feel, talking through that and saying, okay, should these be peer reviewed? How much time should there be for peer review? Is there an external committee that's going to look at these? What's the data framework? Again, is it an external committee that's going to look at it? What's the funding arrangements for evaluations? Is it an open evaluation? What's the minimum time for an RFP? All those kinds of things, for me, would come under governance arrangements, which I think are the first step on this.
Yes, Ramanan.
So I think Margaret explained this really well and probably more eloquently than we probably explained it to her. The first one, I would link it to what Nachiket also said, which is not just connect to policies on maybe put that up there, Sachi. I think you said it, but if we should make sure that it doesn't come back as, oh, but we have a lot of policies. I think these are not policies on quality. They're really the broader set of connects, everything from medical education, which actually is a huge driver of substandard quality, to hospital programs, who gets allowed to set up a hospital, health financing, and so forth. So sort of the systemic influences of policy needs to be set out.
Sheila, respond really quickly to both. I think that in some ways, the reason that ended up first on our list and ended up being a big part of the discussion is because it feels like then the facility level QI improvement efforts, or the quality improvement efforts, are then the Band-Aids, like the patches, right, on a system of policies that were really never implemented in the first place. And I think that's what we're trying to raise here, that we, yeah. And then thank you, Jishnu, for that. I think it was 5 things here, and this is definitely the 6th. And I think this is also an area that we spent a lot of time thinking about in the earlier report of the committee. But I think the bank has actually shown, is a great example of how one can clarify, right, look at itself critically and clarify how, in fact, more knowledge and better knowledge can be generated through the investments we're already making.
I see lots of hands going up. Nashket.
One plug I would make also is to add the whole theory bit to it. I see a lot of studies, research studies, in which they've gone to the data, produced some answer. I don't know what is the theoretical construct behind this. Just like you don't see the gut of the implementation, I often don't see the theory. And I worry most about this in the RCT type work, in which you're simply being given an issue that's being tried out, but you don't know what is the theory behind it. So because you don't know that, you don't know, do I implement this idea directly elsewhere? Or is this actually telling me about some hypothesis that was there? It's validating the model. And then I take that model and implement it elsewhere. So
Yes.
Yeah, I wonder if the group discussed, because when I look at these points, is it very high level research, which is RCT and others? Did the group also think about operational research? Because quality improvement really is about implementation science, building it back into it, and to actually support strengthening the quality. Did the group look at that aspect of research?
Absolutely. I think we, if you, for instance, point 4 is really getting at that notion of situating the research in a context, in a need, understanding what it is we're trying to solve for. But at the same time, I think sometimes the bucket called operations or implementation research is very wide indeed and permits, acceptance of anything with data in it. And I think we were really careful to specify here that we are talking about evaluation and learning and something that could be generalizable with an understanding that context matters and capturing that, but really distinguishing between evaluation and monitoring, which has to happen for different reasons, right? But for the learning agenda, we need the more robust research. Whether that's randomized every time, not necessarily. It could be quasi-random. There could be other ways to account for the counterfactual. So we're very much in line with rigorous implementation research.
Yes, Paul.
I was looking at number 4, and kind of my standards writing bent comes out on this. It's quite comprehensive, and it describes different processes. The first one is really kind of a situational analysis or a readiness assessment. It's understanding what the real problem is. The second is matching up what you understand about the problem with the different solutions that are possible and picking within the system where that intervention should go. And then the third is actually the implementation of the solution. Now, my curiosity is, should that all be done by the same group, the same people? Or is that really 3 different processes that could or should be done by different groups?
very briefly, absolutely, you're rightly noted our strategy for lumping to keep to 5. But in fact, it's an excellent point, and it links to the notion of governance. Who gets to define the quality problem? Who acts on it? And we really see that as being in the realm of policymakers and communities, and with the assistance of development agencies to the extent that they play a role in the country's health system, which USAID does in many settings. That's one thing. The assessment of fit and the evidence and so on, that's clearly potentially the job of another body, could be academic institutions and others. So you're absolutely right. And of course, the implementation, it depends on where the solution lies, who will implement it. So definitely there are multiple, both actors and also activities.
Reminds me of the old statement, if you're a hammer, everything looks like a nail.
Precisely what 4 was trying to avoid.
Okay, Alex?
Thank you. I think all these points are fine. To me, they're also a little bit abstract, and I would offer a concrete idea for moving forward, since the question is how to advance the field. I think all of these points and a few others that have been discussed could be used to develop a research agenda. And I think we're talking about USA, but of course in collaboration with other donors, governments, NGOs, representatives of civil society in the places where this work would be done, I think could come together and produce a research agenda and then have funding linked to that agenda. And the reason I say that is that I've been concerned, just looking over, taking a view, my own view of the literature, is that after 4.5 decades, our understanding about what really works is still not all that crystal clear. And I'm certainly not the first person who has said this. And the idea is that I think the need for improving quality more rapidly is so important that I'm worried that if we wait another 4.5 decades, we'll only be sort of incrementally a little bit further along. And so a coordinated research agenda, and again, having funding following that agenda with these kinds of elements in it, might be a concrete step forward. Thank you.
And certainly we hope to be able to craft an agenda that speaks to all 3 of these areas. So I'm going to use the chair's prerogative and apportion an extra 10 minutes to the rest of the sessions, because we're going to be hearing from a number of people at that table, some reflections as well as how to move forward. So thank you very much. Thanks to all in the room who contributed. And Jim, I'm going to invite you to come forward.